Okay, so I'll start with cardiac CT and MRI because I think the cardiac CT and MRI are less they are not as taught as they should be. So we'll go over the cases, and as we present the cases, I will try to also give the approach that you should probably just keep in your mind. So the first case is a 53-year-old male. Okay, how can I take this from my way? So this is a 53-year-old male patient who he's asymptomatic, and he has an LDL of 3.3. He's not a smoker, and his Framingham risk score is around 7.8%. He underwent a calcium score for risk stratification. It's a very straightforward case, and it's very common in cardiac imaging practice. This is his coronary CTA with calcification. And I want you to go through this and watch what you see carefully. And I don't know if you guys are doing this or not, but this is the sequence of calcium score, and we can see the calcification appearing spots 1, 2, 3 in the left main LCX, in the LAD, in the diagonal, as well as in the RCA. So the patient has calcification in all of his 3 coronary arteries. The question here is, what is the finding? So we have a calcification everywhere. Now, do I need to quantify the calcium or not? Show of hands, please, and anyone can answer.
Now we can use the Gadsden score to quantify
Sorry?
the Gadsden score to quantify the calcium.
So you want to use the Gadsden score for assessment, or sorry, for quantification. Is there
Yes.
any other tool that we use to quantify calcium score?
I don't know.
Any methods extra? So there are 2 extra methods for assessment or quantification of calcium score: the mass score and the volume score. So there is a Gadsden score, the mass, and the volume. These are the 3 tools. The most validated and used is a Gadsden score, and that's what we use. So this patient has a Gadsden score of 275. The next question is, the next appropriate action in this case is lifestyle modification or primary prevention, for primary prevention of cardiovascular events, or initiation of statin for primary prevention of cardiovascular events. Consider functional testing with a nuclear myocardial perfusion scan or stress MRI, or send the patient for coronary angiography. This you can use the chat if you want to put what you vote for. So asymptomatic patient, you know, okay, I see answers. Good. So without names, they say 2, 2. Anwar's iPhone is saying 3. iPhone. Mishal lifestyle modification, which is 2, 1. Okay, so lifestyle modification. So the guidelines for prevention Once you commit yourself to doing calcium score for risk stratification, you better act on it. So in the limit for calcium score that probably warrant starting statin therapy is at what? Can you throw in a number? Maybe I forget this. For prevention. No answer? Okay. So I see a few answers. Actually, it's around 130 that has been the cutoff limit to start the statin in patient who came in for the for assessment or for primary prevention. Now, for the initiation of statin for primary prevention of cardiovascular events, given the risk. So the right answer here is statin therapy in a 53-year-old male patient whose LDL is 3.3, and he has a Framingham risk score of 3.8%. Okay, next. The second case is a 48-year-old male smoker who was referred for chest pain assessment. And I will show you the CT images here. So this is the calcium score. The first that I'm actually showing is the calcium score. We see that there is a calcification in the left main and the LAD, as well as in the diagonal. And there's also some in the RCA. If we don't know if the clip, yeah, there is also in the proximal RCA. There is also in the mid RCA. So there are areas of a confirmed plaque in the calcium score. In CTA, as we see here, the left main has no lesion. As the bifurcation happens, so here I will show you where's the so look at the origin of the left main is actually good. And as the left main is bifurcating into the LAD and the LCX, there is a lesion in the proximal or the ostial LCX, but it's not occlusive. If you look at the proximal LAD, there is no occlusive lesion. Then after the first diagonal, there are actually areas of haziness and probably it's occlusive. So as we will see in the next slide, using the multiplanar reconstruction of the fissures, we can see that there is this lesion. Look at the cross-sectional of the LAD in the mid LAD. That diameter is actually disappearing and then appearing again. Now, looking into the quality of the study and the disappearance of the mid LAD or haziness or narrowing, which probably indicating that there is a disease. So what is the finding here? Anyone can contribute to describe if you see any of that. One, there is a calcification in three coronary artery, the three fissures, in the LAD, in the LCX, as well as in the RCA. There is also non-obstructive lesion in the proximal LAD, the proximal RCA, as well as the proximal LCX. And the third, there is a obstructive lesion of at least 50% or more in the mid LAD. So once you have the luminal or the diameter of the reduction by 50% or more, this is obstructive by definition of CTA. And so given the history and the imaging findings, the next appropriate action in this patient is Number 4, coronary angiography. I agree with that. Now, why didn't we choose the number 3? So good. All the answers are actually good. Here it comes to your clinical judgment. You could have sent the patient for a perfusion scan if you did not want to, or you want to really minimize the intervention. But this type of patient, first of all, he's young, he's a smoker, he has a chest pain that was described as a chest pain, and there is a clear obstructive lesion in the mid-LAD. So I think ideally we should send the patient for coronary intervention. Okay, so case number 3. This is a 43-year-old male, non-smoker, works as a teacher, and he has a family. These CT and MRI cases are real because I do them every day, and they are almost my patients. But I know what happened to them and what did we find. So, but there is no time to go over every single case and details. He has a family history of premature coronary artery disease and experienced chest pain episodes, mixed in nature. His LDL is 2.3, his hemoglobin A1C is 5.2, and his blood pressure is 133/78. So this is his coronary CTA. So you can describe what you see. I think this is probably straightforward. Okay, so let's see what are the answers. So maybe it's not really clear what we see. This is not calcification. This is CTA. It's not the coronary calcification sequence. You see the contrast in the aorta. You see the contrast in the coronaries, as well as opacification of the left ventricle clearly. So what you really see is not calcification. I did not see calcification. That's why I didn't bring a calcification sequence. So okay, so maybe, okay. So again, what you see is the contrast. He does not have any calcification. This is all the contrast in the vessels. You see it going all the way down the left main, as well as the LCX beautifully, and the LAD. You see the RCA going and between the atrium and the right atrium and the right ventricle, giving you the first branch and passing through the into the groove, and then bifurcating, giving you the PDA and the LV branch, so which is clearly very dominant and very beautiful. So he has no chronic calcification, as well as he has a normal, no obstructive lesions. He has also no plaques. Okay, so I agree, it's actually normal. Such patient, you in the report of the CT, excellent. So I see 1. The next appropriate action is this patient has no chronic calcification, he has no plaques. This will dictate our decision for primary prevention. So what he really needs to do is lifestyle modification and control of risk factors according to each risk factor guidelines for primary prevention of cardiovascular, which is number 1. Next. This is case number 4, which is 69-year-old female who with chest pain on and off exertion mixed in description with shortness of breath. She has hypertension, type 2 diabetes, and dyslipidemia. She underwent the CTA, and this is her CTA. The first one, which I would run now, is the coronary calcification sequence. Okay, and the next we will, okay, so let's see what's going on with the calcification. I'll play it again. So, calcified plaque in the LCX. Someone also, RCA also, extensive calcification, osteal lesion in the LCX. Okay, so let's go through it quickly. This is the origin of the left main here. It's not calcified. There is some calcification in both RCA as well as the LCX. Sorry, there is also in the left main at the junction with the LAD. There is also some calcification, as you see, in the mid-LAD. The RCA has calcification also. There is also calcified aortic root, and probably she has some early calcification in the mitral annulus. So clearly that there is an atherosclerotic process that started to originate in calcification in the coronary arteries. Now looking into the CTA, which follows the coronary calcification, we can see that the left main, there is actually the distal left main and the junction with the LAD. Here, you can see that there is a calcified plaque. There is a large ramus that has some calcification and plaque, which is not obstructive. And the origin of the LCX has a large calcified plaque, which deemed this segment to be non-evaluable, because the problem with calcification is giving you this pluming artifact or beam hardening, which is seen in the previous cases. Now, when we go down to the mid-LAD, there's also some lesion that we are not sure about. There is calcification in the RCA as well as the mid-RCA. There's a big chunk of calcium in the mid-RCA, which you see now. So we will do the multiplanar on some of these lesions to confirm how severe are they. So definitely that the patient has multiple plaques. Now, when we do multiplanar for some of these lesions, and I chose the middle AD lesion, look at here at the luminal diameter. It's really beautiful and patent. So you go down the artery, it's a little, it gives you the branch, one of the diagonal, but then it gets narrowed. And we are not really sure, is this 50%? Is it less than 50%? Definitely it's not severe, or which is 70% and above. So given that the patient, given the findings, as well as multiple plaques that are non-evaluable, like the big chunk calcium at the proximal LCX, as well as the big chunk calcium in the mid-RCA, what do you think is the next appropriate action? Okay, so we get a few people actually answering or responding between number 3 and number 4. So I think it's the most appropriate action is probably 3, which is going to clarify whether these symptoms that are of a mixed nature. If you go back to the testing, the questioning in the exam is very important. when we say here that the patient has a chest pain on and off exertion, mixed in description with shortness of breath, there is hypertension, diabetes, it's actually guiding you to a proper answer. I don't put questions, so I don't know, but this is actually the way the questioning in exams usually work, is guiding you to one of the 4 choices or 5 choices you're given, as well as to fit with this finding. In fact, this patient appropriately, she was sent for a nuclear perfusion scan, which is choice number 3, consider functional testing, and it came back negative. Okay, so next. This is a case of MRI. A 48-year-old male smoker drinks alcohol occasionally, according to him. He was admitted with a new diagnosis of severe LV systolic dysfunction. And his LVF was around 23%, around 25%. This is a very real practice or real life case. CTA was done and showed no obstructive coronary artery disease. Now, describe the findings on this delayed enhancement imaging, and we'll answer the question number 2. So let's look at, this is a short axis starting, if you're not oriented to the anatomy, we're actually at the base of the left atrium. You see the white, guys, do you see my cursor? Okay, so this is actually at the junction of the left atrium and the LV, as well as this is the right atrium and the RA. So this is the base of the mitral valve leaflet. Now, when I'm going to scroll, I'm scrolling from the base to the apex and looking at the myocardium in 10 minutes post image 10 minutes after injecting the patient with the gadolinium enhancement agents. So we go through the scroll down through the case. Now we're scrolling down. As you can see, the myocardium to the apex. So go back. And then I want to see what you guys think about it. So going down, I mean, I went up and then down. So up and then down. So slowly. You see the LV, short axis, the myocardium, beautiful, black. Blood is white, and then so I want a description. If you guys have been through the description of delayed enhancement, how would you describe a delayed enhancement? You need to describe the location. Is this subepicardial, mid-myocardial, or subendocardial? 2, extent. Is this extending 10%, 20%, more than half, or transmural? And the 3rd is, where is it, which territory or which location of the, which segment of the LV? So let me just see here. Answers. Those who already passed the exam are not allowed to. Think he knows who I mean? Okay, can you repeat it? I will repeat it. So from here, we're going down the left ventricle. Mid, distal mid to distal, distal, apex. Okay, so let's Okay, so now look at the myocardium. This is the myocardium black. Here you start to see some changes in the subendocardial. So this is subendocardial, started from the endocardium all the way down to the epicardium. So this is the epicardium, mid-myocardium, endocardium. So that started to be subendocardium delayed enhancement. That enhancement is actually mid to distal, and it's going down. This is very clear. That's actually a very focal subendocardial enhancement, not be missed by anyone who actually already trained or read the MRI and goes down. It is distal mainly. This spot is distal. Now the question here is which segment of the myocardium, or it can go transmural. Someone wrote transmural. It can go, but it's actually only 50% or less of the myocardium. And the more important thing is, where is it? In which territory? Which segment of the myocardium? So we know that here, north is, this is the anterior, anteroseptal, inferoseptal. This is lateral or anterolateral and infralateral. And this is the only clear lateral wall. So it is started a little bit infralateral, but as we go down, it is more of inferior. So this is likely to be, maybe the septum is a little bit affected. I agree. But the most of it is actually in the inferior wall. So this is inferior wall, a WAB. Yes, inferior wall. The question here is, this is a subendocardial focal inferior wall. Question number 2, the cause of his heart failure is ischemic cardiomyopathy, dilated cardiomyopathy, alcohol cardiomyopathy, or myocarditis. Ibrahim, we want people to talk, just to understand how do they think and what would they want to comment on LV size. Comment on LV size, Dr. No, LV size was normal. The only thing, he was severe LV systolic dysfunction. It was not dilated LV. And that goes also with what you see on the delayed enhancement. Okay, so those who actually answered alcohol, can you justify why did you say alcohol? The guy came in with 23% of ejection fraction, and he has a finding of subendocardial that mimics ischemic cardiomyopathy. Anyone can answer? Okay, so the right answer here is alcohol cardiomyopathy. And the reason for that is, number 1, this is not ischemic cardiomyopathy. This is a very focal, does not correlate with the ejection fraction. It's not extensive ischemia. Okay. Islam من بدري يا جماعة تكلموا عشان بس. Yes, so the finding does not correlate with the ejection fraction. Number 2, his LV dysfunction exactly is out of proportion to the ischemic scar that we see. Number 3, his LV was not dilated, so this is not dilated cardiomyopathy. And number 4, there is no evidence of myocarditis on this cardiac MR, which was actually done with his acute presentation. And finally, his CT was done, CTA. We did not even do cath and showed no obstructive coronary artery disease. How do we confirm this? It is by the response to therapy, and his main therapy would be Alcohol abstinence, excellent. So stop alcohol, you immediately, the myocardium is not really scarred, it recovered completely. Alcohol, tachycardia induced, peripartum cardiomyopathy does not cause a scar, and the likely of actually response and recovery, fast recovery, is high in these patients. Okay, next. This is a 66-year-old male with a new diagnosis of acute decompensated heart failure. He had an coronary angiography, which showed a diffuse coronary obstructive coronary artery disease. His delayed gadolinium enhancement MR was done and shown here. So the question is, describe what do you see actually. Should you recommend revascularization or not? And justify that. So this is a delayed enhancement imaging too for the patient from the base to the apex. This is his delayed enhancement from the base. Cardiac MR images are not well done. He was moving or breathing, but you can see the myocardium and the changes in the myocardium. Okay, so I think it's probably ready to comment. So it's not diffuse actually. Okay. So let's start from here. We see delayed enhancement in the basal, lateral, and infralateral. As we go down, continue to go med, distal, distal. The apex is kind of preserved actually because it's supplied by something else. So again, basal med to distal, subendocardial delayed enhancement. What is the extent? Well, it actually eats most of the myocardium. So I would say it's more than 50% of the myocardium, almost in areas, total transmural scar in that area. Now, as we go mid to distal, you can see that there is another scar that appears to be here in the anteroseptal, and this is where it starts. And it's actually very important to realize that this is going to apex. So that is coming from another artery that supplies the lateral and infralateral. And the extent of that scar, which is subendocardial, is only probably less than 25% of the myocardium. So that is the proper description. There is a subendocardial delayed gadolinium enhancement in the lateral, infralateral, from basal to distal. And there is also this extent up to more than 50% to transmural in some of the segments. There is also subendocardial, mid to distal, anteroseptal, I agree, that is only extending less than 25% of the myocardium and involves the apex. So the first scar is consistent with ischemia in what territory? And the second scar is consistent with ischemia in what territory? Okay. Yeah, it's the first scar that actually involves the entire lateral and lateral or infralateral is consistent with ischemia in the RCA/LCX dependence on the dominance. The second is consistent with ischemia in mid-to-distal LAD. So, giving all this information without even looking at the coronary angiography, and you sit in the heart team meeting, should you recommend revascularization or not? So the first two questions, the first few answers. Okay, so LAD only revascularization. Here, recommend revascularization. Yes, yes, more than 50%. I didn't get it, but if you are actually justifying revascularization by more than 50% late gadolinium enhancement, then this is wrong. In fact, you should not recommend revascularization because that indicates non-viability. But probably, so, okay. Do viability, I think we are viability here. We're presenting a viability study. So viability are two things, either FDG, well, it's not only two things. There are four major modality for viability that we could just touch base on if we have time, but revascularization of LAD, not RCA, LCX. Okay. So coronary angiography was done already, and patient was sent to the cardiac MR after coronary angiography to assess the ischemic burden or the ischemic scar burden. Yeah, so just make it simple. If you have ischemic scar that is less than 35% to 50%, this may indicate viable myocardium, though all the evidence saying if it's less than 10%, it's viable. If it's more than 90%, then it's not viable. And in between, sorry, if it's more than 50%, it's not viable. Between the 10 to 50%, questionable viability. But we never had any really evidence that looked at patient prospectively, targeting the viability itself and the response to, or assessment of viability modality and the response to revascularization. All trials do not have a one way of assessing viability and looking at the outcome on a longer term. However, what I tend to, and what you, to answer this case, the LAD, ischemic territory area, seems to be viable, and that's the report that I wrote. The RCA LCX seems not to be viable. What really matters in revascularization, and this you will see when you sit on heart team meetings, it's actually the LAD, because it's the lima that may or play the role in or durability. So is that clear? Any question about this before we just move on? Okay, so I will go over now to nuclear cases. Bear with me a little bit because I need to. I need to share this. Okay, so you guys still see my screen? So let's start with case number 1. This is a 60-year-old male who was admitted to the hospital with a 2-day history of pain in his left shoulder area. His pain would occasionally worsen with exertion and may also be present in his chest. His only associated symptoms was shortness of breath. He has a risk factors of diabetes. He's an ex-smoker, and his physical examination was unremarkable. First thing is, what is the pretest likelihood of chronic obstructive coronary artery disease in this patient? Someone to answer? And why?
Can you go back to the question, please?
Sure. So, okay, so sure. Sorry, what is this now? So again, 60-year-old male patient. Okay, so high or moderate? Want to see more? Yeah, we made this question before changing the cardiac to non-cardiac, cardiac and non-cardiac only. Typical versus atypical is a little wishy-washy here. But anyway, so moderate to high, okay? You don't want to miss anyone, either moderate or... It's not low likelihood, definitely. So he underwent stress myocardial perfusion testing system, maybe using Bruce protocol. He did exercise. This is exercise, which is really better than the pharmacological. And his heart rate went from 68 to 120 and increased from the blood pressure also increased to 174/80. And he did not have any chest pain. So I'll give you the images now. The peak exercise ECG, the rest and stress perfusion imaging. And again, look at what would you do next? This is his rest ECG, as you see. It's normal. This was made before a few years. This is his exercise or ECG at the peak stress. So comment, please. I want someone to speak about that. Come out and talk. Unmute yourself and describe what you see.
Okay, I will take it if you don't mind.
Go ahead. I don't mind anything.
Okay, so there is an infralateral downsloping ST depression. There is no significant ST elevation. There is a little bit ST elevation in the AVR. So ST elevation in the AVR with like 5 leads ST depression. So this is intermediate to high risk stress test ECG.
Yeah, so always try to just describe, because this is, if this was only stress ECG, I would say great to say this is high risk, let's move on in. But because you still have another component. So I agree with you. There is a downsloping ST segment depression. Number two, try to avoid localization if it's not ST elevation. But you can mention the leads. So you can say there is a downsloping ST segment depression in the lead 2, 3, lead 2, yes, lead 2, 1 and 2, as well as laterally and lead 4 and 5. So yeah, I agree. Any other comment? Can you quantify how much of a downsloping, Doctor?
I would say it's not very clear here, but I would say looking at the 60 to 80 millisecond G point, it's around 2 millimeter.
Perfect, amazing, good. Yeah, so always learn to have that guess, always learn to have a gross estimation. It's in fact, it's around 2.5 millimeter downsloping ST segment depression. Very clear. This type of ST segment depression, you don't ignore. Okay, these are the perfusion imaging. And you can see here, you should follow your own approach or an approach in general when you approach any image interpretation. Anyone can take it up and come out to describe what we see?
Yes, I will, Doctor.
Go ahead. Who's this?
Dr. Awab.
Yes, تفضل دكتور أول.
In the short axis views, there is a perfusion defect involving the anterolateral wall with mild reversibility at rest. Also, I can see in the inferior wall, in the horizontal long axis, there is a perfusion defect involving the inferior wall with mild reversibility.
Okay. Can you describe for us what is your approach in imaging interpretation? So one of the most important things, Victor, for everyone is perfusion defect. You have to see that in at least two
different views.
Yes, so two different axes or planes of view. So short axis, long and horizontal. So you see it in the short, then confirm it with the vertical or the horizontal axis. Okay, so there is a perfusion defect. I agree in the anterolateral. You said anterolateral, huh?
Yes.
Anterolateral. What segments?
It's from the proximal from the base to the apex.
Do you see it really in the base? Yes. So the base is very clear. Look at the cursor. That changed color. There is a mild reduction. There is a improvement at rest, and they see the mild reduction of perfusion uptake. The way I would describe it, you would say there is a mild reduction, mild to moderate reduction in the perfusion, in the radiotracer uptake or perfusion on stress in the basal to distal, basal to distal, on stress, basal to distal segments, anterolateral segments, that is improving at rest, consistent with ischemia in the, what territory is this?
LCX territory.
Anterolateral. Look at this. Anterior wall is affected. Improve.
Yes.
Affected. Improve. Affected. Improve. Then here, it's laterally oriented. Don't forget that we are dealing with images. It's not real heart. This could probably just a little tilted. So then this tells you from the apex going up to the apex to the base. And here it tells you anteriorly which segment you're actually in the anterior wall. And you can look at the lateral here that it's also affected slightly, but not as much as if you look at the anterior. So this is a basal to distal anterolateral perfusion defect consistent with ischemia in what territory?
LAD territory.
LAD territory. What about the inferior? Is there any inferior?
Yes, it looks like there is, but in the short axis views, it looks good, mild reduction with the stress. But in the long axis views, it looks worse. And the perfusion defect.
View, it looks worse. The inferior the inferior wall. Yeah. So look at this. You can see that there is probably a little bit of perfusion defect in the inferior wall. So that is a mild reduction of perfusion or mild reduction of the tracer uptake, indicating perfusion defect or ischemia in the
RCA-LCX territory, I would say.
Yeah, RCA. So this is most likely to be mid to distal only. It's not really very clear whether it's actually involving the base, because look at the base, inferior base is preserved. So it's only mild, it's only mid to distal perfusion, a little slightly perfusion defect. Look at the color, how is it improving at rest? That is the color actually indicating that there is a probably mild mid to distal inferior wall ischemia too. Okay? So back to the interpret the rest and stress perfusion defect. Is this a low, intermediate, or high risk study?
I would consider it a high risk study, given that it's involving two territories and multiple segments.
Because of what? Sorry?
It involved more than one coronary territory and multiple segments from base to apex.
Okay, so one of the most important things that you look at here in the study, it's how large is the area affected. We are dealing with the whole, look, from the basal to the apex. All is affected. Look at this. This is better to see on the in the vertical axis. This whole area is actually affected. Both look at the lung and how many segments are actually dealing with is affected. This is a large area that is affected by ischemia. Number one. Number two, what else you would look for to assess the risk of a scan? So we said how large is the area. Number two, you mentioned multiple territories. So here we have a confirmed anterior wall or LAD, but also could be slightly, there is a mid to distal inferior wall. So there are two at least territories, one large area, two territories. What else you would look at? Features of high scan. You can look at the chat. Some people actually writing for you.
Ejection fraction at rest and with the stress.
So stress. So there is also ejection fraction, drop of ejection fraction of more than
10%.
So people say 10%. Some people say 20%. And the reason is because of the accuracy of assessment of ejection fraction. But anyway, from 10 to 20% is actually considered to be the risk. Yeah, the high risk. What else?
Transient ischemic dilatation.
Transient ischemic dilatation. Now, these images are not really good for assessment of TID, but you could guess that, you know, and the reason here is why TID is actually a sign of high risk scan.
There was multiple theories I have went through regarding the TID, that it's subendocardial ischemia or the actual physical dilatation of the LV.
Yeah, so yeah, so one of the most important thing is when you hit a segment in one territory, that segment is going to be affected. But with the stress in general, your response should be really narrowing or smaller LV volume. Upon ischemia in one small area, the rest of the segments will compensate for that by increasing the contractility. When you start to have affected other segments, all of these segments will actually dilate in response due to that stunning. The whole myocardium is stunned, so the response is always stretching and dilatation. So TID is another one that you have to look at. Eyeballing for TID alone is not really recommended. However, if you are able to appreciate that the LV dilate when it's supposed to be shrinking or smaller, then this is a sign of high risk. So this patient has probably intermediate risk prior to the testing. Upon the stress test, as you see, he developed a downsloping ST segment depression of at least 2.5 millimeter and in several leads. And he did not have chest pain. However, when we look at his perfusion scan, there is a large area of reduction in the tracer uptake in the anterior and anterolateral wall, entire anterior anterolateral wall, consistent with ischemia in the LAD territory. And there is possibly a TID. So what is the cut limit for TID? يا رب ما أكون نسيت بس.
Then 1.2.
Yeah, 1.3, huh? 1.2 or 1.3?
More than 1.
Okay, so 1.2, excellent. So this is for the first case. The second case is this is a 75-year-old woman who had, or she's known for diabetes, hyperlipidemia, and severe osteoarthritis, complaints of tightness in chest and shortness of breath on exertion for several weeks. She was referred for pharmacological stress perfusion imaging and underwent adenosine and rest MPI SPECT. With adenosine infusion, heart rate increased from 70 to 79. One of the most important things, guys, even for your future, when you stress a patient, you have to really describe what was the response to that stress. Because maybe it's not enough as a stress. And I hope they don't really fool people in exams and give you an exam that is inconclusive testing. Baseline EKG had a first degree AV block. She had an intermediate 2-to-1 AV block during the adenosine infusion, and there was no chest pain or ST depression during the adenosine infusion. Okay, so let's look at the images and see what is the interpretation and what is the next step. Someone can take up this. Where's this? Yeah. Anyone? Anyone can take this? Okay, so let's describe this.
No, not mine.
I don't mind. Someone just to go over it, and we will.
I can note in the anterior septum segment there is a perfusion defect with reversibility, with some reversibility at rest. Also, I can notice in the inferior wall there is a perfusion defect with mild reversibility, and in the horizontal long axis, the septal apical, distal and apical areas also there is a fixed perfusion defect with no reversibility.
Amazing, very good, excellent. So there is a large area of perfusion defects in the anterior interseptal. You can see the septum here. How is it really enhancing? And on the rest, while on stress, it's actually defect. It goes from the septum in the distal or apex, going up the way. It's actually improving in perfusion, as well as start to improve in the perfusion in these segments of the anterior wall. It's also improving in the mid segments. The inferior, I think there is a little bit of an improvement in the inferior apical perfusion, but there is no perfusion defect in the mid as well as mid to distal inferior. What about the apex? What did you say? If you look at the apex, there is actually a reduced uptake of the tracer that is consistent on both stress and perfusion. So your conclusive is this is ischemia where?
And mid to distal LAD and RCA. I guess the area, the apical area and septal apical areas is scarred with no reversibility on perfusion there.
Yeah, so what I expect is this is actually a there is a mixed, so this is ischemia, but that apical fixed is a scar, and it's probably a branch territory too, which is an LAD or a branch from the LAD territory that is completely scarred or occluded, while we still have perfusion or a improvement in perfusion on in the rest of the territory. How do you classify the risk in this study or this scan?
It looks like it involved more than one coronary territory, the LAD and RCA. So I will go with intermediate to high.
Yeah, so I think it's in a high risk scan because it actually involves the LAD in a quite large area of the myocardium.
Okay.
You know, once it's involved an LAD in a multiple segments, it's probably high risk. They should improve after revascularization, maybe. So your next step is?
Coronary angiography.
Coronary angiography for further assessment and treatment. Okay, let's go to case number 3, just for the sake of the time. This is an 82-year-old male patient with a previous CABG 17 years earlier, presents with 2 to 3 weeks of increasing shortness of breath, complaining of occasional chest tightness associated with profound shortness of breath on exertion. He had a prior cardiac cath that showed occluded grafts. An echocardiogram performed 5 years ago showed moderate decrease in LV function and concentric LVH. Investigation, he was referred for arrest and delayed thallium scan. I don't know if you guys are doing this, but it's the same concept of perfusion. And this is his thallium. Sorry, just I'm responding. Okay. So what do you see on this? If you can comment and tell me, this is the thallium wrist and delayed imaging. So this is thallium can be used for both perfusion and viability. So if I go with you over this, this is actually short axis going from the apex to the base. He has no perfusion at all at base and in the apex as you go up to the base, and then he starts to have some perfusion with the preserved delayed imaging. Delayed imaging, it takes up to 70 hours post thallium injection, which indicates that the myocardium in this area is preserved. So this patient has a fixed anterior interseptal as well as inferior defect in the whole apex, entire inferior wall. He has only preserved lateral wall, and this deemed him to be, based on thallium scan, as a as non-viable myocardium, as well as no active ischemia. You can look at this. This is very fixed defect in the apex as well as septum and the anterior wall. The only preserved perfusion and viability is at the base, anterior lateral, and the entire lateral wall. This is case number 4. Following low-level exercise technetium, systemic perfusion scan was performed in a stable patient following MI treated with TPA. This is an old practice. They used to do it, but let's look at the imaging findings to learn from it. It was referred for rest and delayed thallium perfusion scan. Question 1, what did the presenting ECG look like? Where is it? Sorry, this is not. Sorry, I'll jump the this case for the ECG, and then we will go over the imaging. This is different imaging on thallium. You can see that there is a preserved perfusion in the apex as well as in the entire myocardium. However, it is a little reduced perfusion in the anterior interseptal wall compared to the rest of the myocardium. That's on stress, and then on rest, you can look at it in the delayed imaging, which showed that this is a viable, but it's actually active ischemia. This is the last case, as I have to really go. This is a 50, this is the case where I'll show you the ECG. It's at rest. Can someone take a lead in this?
Okay, so the profound finding here is the left ventricular hypertrophy with an ST changes due to the strain pattern. So this patient is not fit to go for ECG stress test.
Okay, so he goes for exercise nuclear perfusion scan, okay? May?
Yes.
Okay, so what do you see here?
Yeah, so there is an profound ST depression in the same areas there was a baseline of ST depression at rest. Again, the LVH is showing here. So I don't think this is a very reliable ECG to comment on the ischemic burden, as there is a baseline of ST changes.
Okay, so then we go to perfusion scan. What do you think about the perfusion scan?
There is no clear ischemic or diffusion defect. However, there is a dilated LV. And I think there is an RV uptake. I'm not sure if this is accurate or not seeing on the short axis, but there is dilated LV at rest and stress with
Yeah,
no
so
perfusion defect.
sorry. Yeah, so looking at this, if you look at it, it's actually the nuclear perfusion scan can be you don't really see a clear perfusion defect as you mentioned, but what do you really see in this? What's remarkable about it? Two things you mentioned. The first is the LV dilatation, and the second is there is some RV uptake. So how would you classify, or what would you answer the reporting or the?
I would say dilated cardiomyopathy could be balance ischemia if it's done with the specs or need PET scan or coronary angiography. And if there is an RV uptake, 2RV uptake, this is a high risk scan.
Yeah, so there is a TID, there is an increased uptake in the RV, there is no focal or clear perfusion defect. However, this is consistent probably with high risk scan and balance ischemia. I recommend coronary angiography or anatomical assessment. Okay. Fair enough.
Can't we from this study, I mean, judge the patient as having non-ischemic cardiomyopathy?
It's very difficult to judge patients not to have ischemic cardiomyopathy when you have evidence of dilated cardiomyopathy on stress. You have to look at the anatomy to say 100% there is no coronary artery disease as a cause of cardiomyopathy.
I mean, from the beginning, patient presented with dilated cardiomyopathy, better to go for anatomic assessment rather than functional.
Rule out ischemia. It doesn't matter. But here you have to, are you able to say that this patient has no coronary artery disease? It's very difficult.
Okay.
So anatomy is important to rule out coronary artery disease in patients with LV systolic dysfunction. Anatomy assessment is very important because even if they have dilated cardiomyopathy, they showed, that's why it's actually recommended over the ischemic or functional testing.
Okay.
So this is the last image. I just want someone to take over it and describe what you see. It's actually flipped stress and some rests. Anyone? So very clear perfusion or reduction in the uptake of the tracer, radio tracer, in the anterior anteroseptal, okay, that actually improves at rest. There is also some improvement in perfusion in the apex and also the in the distal anterior wall and anterolateral. Okay, you can look at this here, and this is a stress versus rest. This is improvement, a little improvement in the perfusion anteriorly, although you don't see it here. One of the things that you may limit it is actually the cut through the horizontal or vertical, vertical and horizontal, both of them. But you can see that there is an improvement here, slight improvement here in the perfusion defect. That is not consistent here. So that's the area where you see the ischemia. And the horizontal also, this is confirmed as you go through the segments with a mild improvement on rest. One thing that you have to look at is also inferior. So the basal inferior is showing some improvement in the perfusion defect. So this is a multi-territory or two-territory, which is LAD and RCA ischemia. Okay, so I think this is all what we have today, and I wish you all the best. Thank you.